invite Dr. S. Rangalakshmi, Professor Head of the Department of Anesthesiology from Rajarajeshwari Medical College, Bangalore. She did her MD from Safdarjung Hospital, New Delhi, and she's moved to Bangalore and worked in various medical colleges in Bangalore. At present, she is Head of the Department in Rajarajeshwari Medical College in Bangalore. Has given several guest lectures in conferences, both national and international, has conducted several workshops in Gasman simulation and both national and international conferences. President of Karnataka chapter of Indian Society of Anesthesiologists in 2014 and has 30 publications and authored a chapter in textbook. Areas of interest are regional anesthesia, computer simulations and daycare anesthesia. Carrying out several research projects in regional anesthesia and pain clinic. Madam, the stage is yours.
Is it on? Thank you, sir. Thank you, sir. Making your acquaintance after a long time. It was nice to meet. And my topic for today is anesthetic management of polytrauma with grade 5 liver injury for laparotomy. Thank you, the organizing committee of South Zone SZISACON for having me here. Warm greetings from Rajarajeshwari Medical College, Delhi. Bangalore. All of you are welcome there at any time. I am Dr. Rangalakshmi. So I'm going to be talking about this topic under, I'll be touching on the major anesthetic challenges, some classification of liver injury indications. It's going to be critical care and anesthetic management and other injuries, concomitant injuries. I'll just be touching on that. What are the various challenges in polytrauma? There are always multiple challenges. We have limited history, we have hemodynamic instability, we have limited time for optimization. We are just going to take up the patient as it is. And the just to complete, most common cause of death after polytrauma is traumatic brain injury, followed by hemorrhage, liver and other abdominal injuries, and pulmonary embolism. Now, I'm not going into all the grades, but suffice to say that grade 5 liver injury is associated with extensive vascular lesions, extensive parenchymal lesions, more than 75% hepatic lobe disruption, and it can be a hepatic venous injury, and this is often associated with hepatic vein, portal vein, or hepatic artery injury. Now, usually this is caused by gunshot injury and penetrating injury to the liver, also in motor vehicle crashes if they are punched in the stomach, and it's often associated with concomitant chest trauma, lower rib fractures, injury to the diaphragm, small bowel. As anesthesiologists, we need to be aware of all of this so as to keep a watch whether these are present. Then often there is also an associated pneumothorax and renal injuries. So look out for that too. We are going to be called to do a pre-anesthetic evaluation from the ER. So look at airway breathing and circulation, look at the mental status, the extent of injuries, then always do an injury severity score and decide whether the patient is, the case is emergency or can be postponed till the patient is stable. Always coordinate with the ER and the trauma surgeon. Send basic investigations immediately, that time itself arrange for blood, and diagnostic peritoneal lavage was what used to be done. Now all surgeons also do an E-FAST or a focused abdominal sonography of for trauma in order to just categorize and see what is happening. Coagulate profile should be sent, and blood grouping and cross matching of course should be done. CT can be done if the patient is stable enough to be shifted to the CT room. And what is E-FAST? E-FAST is just a limited ultrasound scan of the right upper quadrant, left upper quadrant, subcostal, pelvic, and a brief ultrasound of the lung, where we are going to look for intra-abdominal free fluid, pericardial effusion, major hemothorax if present, and pneumothorax. CT can pick up every other thing. Now, if there is a liver trauma not responding to resuscitation, the patient, surgeons always take them up for laparotomy. Nowadays, there are new modalities of surgery. That is, they do an angiography, they can embolize the artery if there is. They do try all of this before actually opening it. Then ERCP, stenting of the ampulla, is always done. When again, even a grade 5 liver trauma, have a good femoral or a high flow venous catheter and activate the massive transfusion protocol immediately. So before going to massive transfusion protocol, the table on the right gives you classification of hypovolemic shock as per the latest ATLS guidelines. Now, class 4 is what is requires massive transfusion protocol, where the blood loss is more than 40% and the base deficit is more than 10. So, it is defined as a transfusion of more than 10 units of blood in 24 hours or more than 4 units in 1 hour. Of course, before the blood comes, always start a resuscitation with crystalloids, warm crystalloid 1 liter. And then while the blood comes, we have to always do a goal-directed therapy where there is a point of care testing. If it is possible, please do a TEG or a ROTEM. If it is not, give a fixed blood ratio, ratios of blood products, and associated always with other agents, especially in a massive transfusion protocol. Give lyophilized factor concentrates such as prothrombin complex concentrates, recombinant activated factor 7, and a fibrinogen concentrate. Antifibrinolytics, aminocaproic acid or tranexamic acid is a must. And if you don't have TEG or ROTEM, monitor the PT, APTT, INR, fibrinogen level and the platelet count. Associated, of course, we all know that in any massive transfusion, there is going to be a citrate toxicity. So, 1 to 2 grams of calcium chloride or 3 to 6 grams of calcium gluconate, followed with ionized calcium monitoring. Tranexamic acid, 1 gram should be given. If the patient is on anticoagulant, review it, stop it, avoid hypothermia, acidosis, and target a lower than typical MAP. These were two huge studies which were conducted in the US of A, where they surveyed trauma victims of nearly 10 to 12 trauma centers, and this was in the 2013-2014. And what they found was that at a ratio of 1:1:1 of plasma platelets and red blood cells, or a 1:1:2, that is give a more PRBC, more or less the same as far as the mortality in 30 days, but exsanguination in 6 hours they found was actually better with a 1:1:1, that is less PRBC is fine. This was another study which had similar findings, which was PRO, PPR, they named it. And I have just put a slide on the rapid TEG interpretation, where depending on the activated cardiac time or the alpha angle, you decide whether to give more plasma, cryoprecipitate, platelets, and this itself is hematologist's domain. Anesthetics can be useful as far as analgesia, sedation in the ER, diagnostic procedures, renal anesthesia, and prep the OR, do a hemodynamic management, critical care, and take care of chronic pain after trauma. Now, analgesia, as we all know, anything which does not cause hypotension, opioids, Dexmed, ketamine will all do. It is an individualized analgesic approach. One interesting article I found was a single inhalation of methoxyflurane 3 ml was found to be as effective as morphine, 0.1 mg per kilogram. This was a huge study which was done in Italy around 2018. All truncal blocks can be given. And the surgery for grade 5 liver is mainly going to be a manual compression, packing, ligation of vessels. Hepatic debridement can be done, will be done of the necrotic areas. When all this does not work, go to a balloon tamponade, shunt or isolation procedures. I'll briefly describe the anesthesia for this at a later stage. Whenever the hepatic artery is ligated, invariably, if it is the right hepatic or the common hepatic artery, the surgeon will do a gallbladder or rather a cholecystectomy because it can cause gallbladder necrosis. In fact, in liver injury, it is the portal vein which is more dangerous. So, an injury to the portal vein is what leads to almost exsanguination of the entire blood, and in that case, these people have tried what is known as a resuscitative endovascular balloon occlusion of the aorta with resuscitative endovascular of the vena cava also. Now, this is an extensive procedure similar to what they do when you have a descending aorta aneurysm, where they place a balloon in the aorta and then you resuscitate the patient and then the balloon is deflated. Liver transplant also may be required, especially when there is uncontrollable continuous bleeding or extensive lesions of the portal vein. The transplant again can be done either as an immediate procedure when it is the new liver is also implanted, or there is a temporary portocaval shunt which is done. Wait for the organ, avoid the congestion in mesenteric splanchnic system, and then transplant it. The OT should be warmed to 26 to 28 degrees at least, with have plenty of fluids, vasopressors, inotropes, blood products, emergency drugs, and airway carts. Transport the patient with oxygen always, have a good IV access, standard monitoring ASA, urine monitoring, and a perfusion index monitoring along with the pulse oximeter does help because it gives a indication of end organ perfusion. Invasive monitoring is required, IBP. If there is non-invasive cardiac output, it's good. Central venous access is required. Special monitoring, either a thromboelastography or a rotational thromboelastography, will guide the use of blood and blood products as I showed. BIS is required. An acceleromyogram which monitors the TOF is also good. You can minimize the anesthetic agents being given. TEE or transesophageal echocardiography with a LITCO or a PICO is desirable. Difficult airway cart with fiber optic bronchoscope and all other accessories. And again, we continue the massive transfusion protocol in the OR. And sometimes nowadays, this is what I read from literature, that surgeons do use a laparoscopic approach and try to ligate. It's again dangerous, but when they do it, as anesthesiologists, we need to be prepared. The mortality in liver trauma is always, which is called the lethal triad, which is coagulopathy, hypothermia, and acidosis. Acidosis itself can lead to coagulation, interferes in coagulation factors and volume replacement. This was a case report which was published in 2017 in the anesthesia analgesia case reports, where a patient with extensive pelvic trauma survived by this resuscitative endovascular balloon occlusion, where the combined endovascular and open liver isolation leads to there is time for you to resuscitate and the patient and perform, that is do a volume replacement. There are 3 areas where this Riboa device can be placed: zone 1, zone 2 and zone 3. I am sorry, they do not have a pointer, so I am not able to point. So I can either have a slide changer or a pointer in this hall, which is why you just need to look at this. And the surgery itself, this particular surgery went on for 9 hours, which included 32 units of transfusion of red blood cells, 28 units plasma, huge amount of platelets, cryoprecipitate, tranexamic acid, and all the vasopressors. Opioid-based anesthesia is what we would like to do always, and with a minimum inhaled anesthetic is fine. With a rapid sequence intubation, we do not know the nil orally status, and this device, what it does is it maintains vital perfusion to the heart, the brain, and there is an increase in the afterload and the MAP. Also, while on the downside there is or can be an increased myocardial transmural tension and the cardiac work pressure. I will just take one more minute, sir, with your permission. The anesthetic pulse is going to be a predominantly narcotic based anesthetic with a less than half MAC of inhaled anesthetic. Aggressive hemodynamic resuscitation. Remember, again, in this balloon occlusion, when you deflate the balloon, there is going to be some amount of, because of wash away of the metabolites, hyperkalemia, lactic acidosis, and profound hypotension can occur. Such cases, re-inflate the balloon and do a slow deflation. The complication, always infection can occur, bleeding can occur even after packing, but the most important complication we need to be aware of is an abdominal compartment syndrome. What happens is VTE can occur, over enthusiastic resuscitation with a lot of fluid and vasopressors and all of that have often led to intestinal edema, which is tightly packed in a closed abdomen. And this was again another big study which was published in 2021. And they said that many patients died not from the initial injuries, from lethal respiratory cardiac failure due to increased intra-abdominal pressure, which again leads to intra-abdominal hypertension. So in such cases, the surgeon has to keep the abdomen open. Postoperative mechanical prophylaxis, LMWH, on a case-based on case base. And to conclude, I would say that polytrauma with grade 5 requires a systemic and coordinated approach to optimize patient safety and outcomes. Grade 5 liver injury is often associated with significant bleeding, and there are several recent advances. This is where we anesthesiologists need to be prepared, aware, and update our knowledge. Management is always a dynamic process. Adjustment, the approach needs to be individualized, adjusted, and close collaboration with the anesthesiologist, surgeon, and the entire healthcare team. These are my references. That's my department. Thank you very much.